I am Monica Fambrough. I'm the communications manager at the Coalition for Global Hepatitis Elimination, and I'm excited to be here today to talk to Dr. Julius Wilder. He's a hepatologist and a gastroenterologist at Duke University, and I reached out to him to discuss a presentation that he recently gave on Martin Luther King Day at Duke University on hepatitis C as a paradigm for social justice. I was very intrigued by the title of it, and I wanted to reach out because we have this new hepatitis equity blog at the Coalition, and I thought he seemed like the perfect guest. So thank you so much for joining me today and talking to me this afternoon, Dr. Wilder. If you'll go ahead and just start and tell us a little bit about what inspired you to frame that talk on hepatitis C and social justice.
Absolutely. When invited to that talk, I wanted to speak to a topic that was relevant to me as a provider, right, as a physician. But at the same time, on that day, I thought it was important that we speak to a topic that embodies what MLK was fighting for and what we continue to fight for today, and that's social justice. And hepatitis C, in many ways, is a disease where the idea of social drivers of health and social justice and equity come into play in terms of contributing factors when we try to understand the burden of hepatitis C, particularly in terms of how disproportionately some populations are impacted by that disease. And so I was excited to have the opportunity to talk about the history of mainly two things: the idea of segregation, as well as the idea of social justice with respect to incarceration, and how those two factors kind of come together to drive what we see with respect to the burden of hepatitis C in communities of color, particularly.
Yeah, that makes sense. And when I think about hepatitis and equity in the United States, one of the things that stands out to me is that, like maternal mortality, it's something that reveals some of the cracks that we have in our healthcare system in the United States. Can you talk a little bit more about the ways that hepatitis C sort of reveals some of the problems that we have with equity in our healthcare system?
Absolutely. Because of the historical implications of things like segregation, we have really communities that are concentrated communities of color that don't have access to high quality healthcare resources. And those same environments create a legacy that results in poor access to not only insurance, but unfortunately health behaviors. And all these factors come together to increase one's potential exposure to things like hepatitis C. If you look, for instance, at IV drug use, that's something that we see more often in communities where folks are segregated, and those same segregated communities have lower healthcare resources, lower community resources overall. And in any society, what you'll see is that things like alcohol abuse, violence, and in this case, injection of drugs can occur more often. And of course, that's a major risk factor, really the major risk factor of hepatitis C in the United States right now. So that's just an example of how things like equity, the sort of the legacy of issues of equity and justice, and how it created the conditions today that contributes to what we see in many respects with respect to particularly chronic hepatitis C and the burden of that on communities of color.
Right. Can you talk about burden a little bit more, and where are we seeing the worst burden of hepatitis C right now in the United States? What changes are we seeing with who's infected and who has access to treatment? Are there any populations that we think it's getting better for or worse?
Yeah, it's really interesting because, there's sort of a couple different sort of stories to how hepatitis C has been behaving over the last really decade or so. With respect to the opioid crisis and the impact of that on, again, people who inject drugs and exposure to hepatitis C, that population manifests as really two spaces. A lot of white folks have been seeing a dramatic rise in terms of the burden of hepatitis C, as well as Native American populations, American and Alaskan Native. We have seen dramatic increases in that population. And in fact, that population probably having the worst increase with respect to the burden of hepatitis C. And that's related to injection of drugs and, of course, exposure to hepatitis C that way. But again, that's primarily in the form of acute hepatitis C. When we look at chronic hepatitis C, right, we see a pattern that we've seen for decades, which is the disproportionate burden of that, particularly in the African-American community. We see that in both males and females who are African-American, and we see it really across the entire life course with respect to age. Even in fact, when you get to African-American males age 50 and above, we see rates that are like 3 to 4 times that of their white counterparts. Now, when we think about so there's acute, and then there's chronic, and then there's actually the mortality. And so when we look at deaths from hepatitis C, again, we see similar patterns where African Americans and our native populations, American Indians, Alaska Natives, tend to have much higher mortality rates. Another group that scary enough that we've seen a rise is in women, particularly in pregnant women. And as we think about moving forward, that's going to be a group that we really have to begin to really sort of hone in on and think about the mechanisms driving that. A lot of that is also injection of drugs as well. But then think about how we can best provide education and treatment for that population. And then another group that really, in some respects, can be the most difficult group to reach in some respects is those who are involved in the justice system. We understand that is a place where hepatitis C is quite prevalent, and there are a number of exposures that occur in that setting. And unfortunately, there are a lot of individuals who are exposed to hepatitis C, may or may not know it. And if you look at treatment of hepatitis C for people who are in the justice system, it's really not consistent as you go from, sort of institution to institution, from state to state. It varies quite a bit. And of course, that can have implications not only on that individual and their health, but they may go back to a community, right? And so that has an impact on the community they go back to. And you sort of create this vicious cycle where individuals who are in and out of the justice system can be bringing hepatitis C back and forth. And so those are probably some major trends that speak to some of the inequities that we see right now.
Right. And when you talk about some of these people, what I'm hearing too is that there's an intersectionality to how people are impacted. You have somebody you have populations, you have people of color, you have Black Americans, and then you also have people who are just as involved. You have people who might be drug users. And so that also calls up is the issue of stigma. And so, in terms of accessing healthcare, how do you see stigma impacting it? And do you see that getting any better, as maybe we are seeing some movement in terms of stigma and the opioid crisis in the United States? It's definitely not a solved problem, but if we see it, improved attitudes towards that, do you have any optimism that we might see some of that access to treatment and people, being held back by accessing treatment because of stigma? Do you think that might get any better?
Yeah, that's a really important point. Particularly when we're looking at this sort of generation of folks who we saw the rise of acute recent hepatitis C infections, developing into chronic, often related to your point, among individuals who inject drugs. Like, how can we get around that stigma? These are often individuals who are underinsured or uninsured, although not always. All these are also individuals who often, some of them don't have, are homeless. Some of these folks, come from various backgrounds, different levels of health literacy. And unfortunately, the stigma that comes with that has been a barrier to us treating them. And that's unfortunate, right? So I think there are two pieces to answer your question. Number one, it's really important that we as physicians take the time to educate ourselves about stigma, to understand where that comes from and how can we ensure we don't allow stigma and bias to impact the quality of care that we provide our patients. I think the second piece of that is us being transparent and intentional about engaging the communities, particularly those communities where stigma could be a risk issue or a risk factor for being a barrier to their care for hepatitis C. We must be very intentional about engaging those communities, doing sort of testing and then of course treatment, and then providing other services they may need. We need to connect them to primary care if they need that. We need to think about how we can help with mental health services or substance abuse services. All those factors come into play when trying to navigate this issue of stigma and hepatitis C. And I think when we think about the idea of potentially one day eradicating hepatitis C, this piece on stigma and all the factors involved with it are going to be key part of that conversation.
Right. And when people are already in a position where they feel like they're being impacted by equity issues, and then you pile stigma on top of that, you really do have a lot of barriers for people to be able to access testing, treatment, follow-up care. And so it's definitely something that we have to tackle, not just through our healthcare system, but also our political system. Are there any policy recommendations that you have? I know that we have such a fragmented healthcare system here in the United States, but on the state level or the federal level, do you think there are things that policymakers could do to try to address the inequities around hepatitis C?
Oh, absolutely. And the thing about hepatitis C is that we actually have data to support these policies. They've researched, for instance, in the justice system, the idea of doing nothing versus testing everyone and treating everyone and ensuring linkage to care after they're released from the justice system. And the data would say that in terms of the cost effectiveness, it makes total sense to do that. Lives are saved and resources are saved by doing that. But it's just a matter of implementing policies within the justice system to do appropriate testing and treatment and then linkage to care. Along the same lines, thinking about needle exchange programs, again, there's data that shows clearly the benefit of that in terms of decreasing the burden of disease within these populations. And actually, the needle exchange programs have benefits beyond hepatitis C.
Right.
And so, again, strong data that support, the benefit of that. And so I would say those are sort of two low-hanging fruit examples of policy initiatives that we already have data that show that they work. And if implemented, the impact could be quite significant and sustainable around hepatitis C in our population.
Yeah, that's really a great point to bring up about harm reduction and what an important piece it is in terms of giving people access. And you don't want to see, somebody who's accessing treatment, accessing a cure, and then going back into a situation where they're getting reinfected because of a lack of access to clean needles. So that's a really important component. Is there anything else that we didn't hit on that you want to kind of cover in terms of equity as it impacts hepatitis C, or the way that hepatitis C actually impacts equity here in the United States?
I say the only other sort of piece around policy is going to be how we leverage Medicaid. That's a population that we know is at risk for hepatitis C, relatively higher rates of hepatitis C. But even among individuals with Medicaid that we know have hepatitis C, their rates of moving forward towards treatment are way lower than they should be. And their rates of moving towards treatment is lower than individuals with Medicare, and then their rates are lower than individuals who have private insurance. And why is that? Well, there are a number of issues in terms of who can treat them, restrictions with respect to the degree of underlying damage to the liver before you can treat, sort of barriers around, sobriety and how that comes into play, whether or not you want to treat. And again, the data would say that none of those are good reasons to not treat our patients. But our policies are not mirroring what the data tells us to be fact in terms of the best way to manage and navigate these issues for our patients. So I'd say among our Medicaid expansions, along with Medicaid expansion, making sure that we create policies and get rid of those restrictions that unnecessarily impede us from being able to move forward on hepatitis C treatment and elimination.
Yeah, it's a real equity issue too in the United States, because if you live in a state that has a certain policy towards hepatitis C treatment and Medicaid, you might not be accessing or having the same access to treatment as someone in a neighboring state that has a more lenient approach in terms of accessing that treatment. So it really can be geographical, in addition to all the other factors.
Absolutely.
All right. Well, thank you so much for taking the time to educate us today a little bit about the equity issues around hepatitis C in the United States. And we'll be keeping a close eye on your work as you move forward in these things. And we just really appreciate the contribution you're making to the conversation.
Thank you very much for the opportunity to share.